Hello, this is Wendy Wood, and I'm going to be talking about dementia today. And the most common form of dementia is Alzheimer's. You're going to hear, though, it's much more complicated than this. There are different forms of dementias, and there are things that can look like dementia. So, to begin with the introduction of what dementia is, we'll talk about the DSM-4 and the DSM-5, and we want to talk about dementia as being a disorder of multiple cognitive deficits that are sufficiently severe to cause impairment in occupational or social functioning. So we'll go a little bit more in depth into that, looking at the different stages. I want to also talk about mild cognitive impairment, or MCI, and we'll be going a little bit more in depth into that later. So that is a subtler form of dementia. It's one that can precede more severe forms. So the diagnostic criteria for dementia are that cognitive deficits must be involved, other cognitive domains involved, and it must represent a decline in premorbid function. Now, this tends to be a progression lasting 6 or more months in duration, and I'm talking about the onset. So, in other words, it's progressive, and it is not delirium. So we're going to talk more in depth about the difference between delirium and dementia. And I already touched upon that in the discussion of pharmacology. So first of all, in terms of dementia, actually 10 to 30% of suspected dementias are reversible type dementias. And delirium would be the first one that we would think of. Depression, many people don't think of that, but depression can be mistaken for dementia. Normal pressure hydrocephalus, we'll talk more in depth on that. We could do a whole lecture on that. So in terms of reversible dementias, delirium, very different than dementia in that it's usually a rapid and sudden onset. The person will display a reduced level of consciousness. They usually have a lot of difficulty attending to things, and they're easily distractible. They may have hallucinations, and they're often agitated. Not always, but often agitated. So some of the causes, usually an acute medical condition, electrolyte imbalance, and an infection. UTI is the most common one, but not the only type. Other toxic conditions, metabolic conditions, and drug reactions is a very big one. Or intoxication. So delirium is one of those things where in the older adult, it could be overlooked. It may be that that patient goes into a hospital. They haven't been in the hospital before, and they haven't been seen, so the person doesn't have a prior knowledge of how they are, and they may put them in that category of having dementia when really what they have is something reversible, delirium. So I just mentioned some of the causes, so risk factors kind of go along with that, and this is right out of your textbook. Hospital admission for an infection or dehydration. We already talked about infection. Physical frailty, visual impairment, severe illness, deafness, multiple diseases, polypharmacy, already mentioned about different medications, dementia. So actually, someone with dementia is more prone to get deliriums as well. So it's almost like getting an exacerbation of their condition. Alcohol abuse and malnutrition. Now, dementia or depression is another form of reversible dementia. And it does make sense, but those who have a loss of health, a loss of a loss of health or loss of function are more prone to get depressed. So the older adult population is more prone to this. The person may display problems with cognition, difficulty concentrating, memory problems, difficulty making decisions, and general slowed thought processes. Looks like I have a typo there. Social withdrawal, somatic symptoms like loss of appetite, sleep disturbances could either be insomnia or waking up very early, waking up in the middle of the night, or sleeping too much. Fatigue, diminished or lack of interest in activities. And it can be complicated because depression and dementia can have both. Dementia can have depressive symptoms as well. So that's complicated. Or depression may occur with dementia. So the person may have dementia first and then get depression. So it can be complicated. So sorry if you heard a growl there, that's my cat piping in. Normal pressure hydrocephalus, as I said, I could do a whole lecture on this. Very, very interesting. Can happen in adults over age 60. And typically there's a triad of symptoms. Gait disturbance, which is usually referred to as magnetic gait. The reason is the person's feet appear that they're kind of like almost stuck to the ground. In other words, they're kind of in a shuffling type pattern. Incontinence and dementia or cognitive changes. And what this is actually due to is the ventricles being enlarged such that they place pressure on the white matter tracts. And the way this is treated, oftentimes, if the person clearly has this, is they'll have a shunt. And what they've done, I've talked to people who've had this diagnosis before. They've actually done a test where they've taken off some of the fluid, taken off some of the cerebral spinal fluid to reduce the pressure, and then immediately had the person walk, and the gait pattern changed markedly to a more normal gait pattern. Older adults can oftentimes end up with this, and it can fall through the cracks. So now in terms of other causes or other reversible dementias, normal pressure hydrocephalus I just talked about, brain tumors, hematoma, other things placing pressure on the brain. So the clinical exam, and I have a couple different items that I've placed in this week's folder. We've got a geriatric depression scale, and I have another item I'll talk about later that I placed in the standardized outcomes folder. Labs are very important. As I mentioned, perhaps the person has an electrolyte balance or something else that's going on, or they have an infection and the white cell count would be increased. More in-depth exams, CT scan, MRI, PET scans, looking at the cerebral spinal fluid, I just talked about that. So those are all, I'm going to go back to that. Those are all different exams which could help and determine whether or not the person truly has dementia or do they have one of these reversible dementias. Wernicke-Korsakoff syndrome, that is a thiamine deficiency, and it could have the appearance of alcohol abuse, but it's very different. Thiamine deficiency, typically the person has antegrade amnesia, behavioral changes, poor judgment, and confabulation. So they're kind of making things up. Thiamine deficiency is reversible. Long-term alcohol abuse is not. So true dementia, there are different types as well, subcortical or cortical, and these have different patterns. So features of cortical dementia, usually there's more severe and prominent memory deficit, both in recognition and retrieval of information. Language is affected, problem solving, and there's usually visual spatial abilities are affected. Whereas in subcortical, there tends to be slowed speech, impaired attention, deficits in problem solving, and difficulty with retrieval, less difficulty with recognition, apathy and inertia. Language is generally spared with subcortical dementia. So criteria for differential diagnosis, unfortunately, that would actually be in an autopsy. So um, a lot of these signs are picked up in terms of, clinical signs. But you may have heard of this already when they've done autopsies on people with dementia. They've seen these neurofibrillary tangles, Lewy bodies, and senile plaques. So plaques and tangles, as well as the Lewy bodies. Now, in true dementia, you have the tau proteins. So I don't know if anybody in our group is familiar with traumatic brain injury, but they also see these tau proteins in persons who've had traumatic brain injuries. So some of the football players, boxers that have donated their brains, they've really seen these problems. So you can see a difference in some of the healthy neurons versus the tau ones. So here's a picture of the neurofibrillary tangles that are seen in dementia. And Lewy body, so Lewy body dementia. So these again are things that we're seeing at the cellular level. Senile plaques, here's some slides of these here. So how do you diagnose dementia? Well, we are going to talk about the MMSE, the mini mental state exam. I won't be talking about the blessed in this lecture. Come back to that. So the clinical criteria in the diagnosis, some of the differential diagnosis: Alzheimer's disease, dementia with Lewy body, vascular dementia, and frontal temporal dementia. Alzheimer's disease is the most common form of dementia, so it's comprising about 77% of dementias, followed by Lewy body, and followed by vascular dementia, and then some others that are much rarer. In terms of dementia, it's usually a cortical pattern, slow progression, death in 7 to 14 years, and motor decline is usually later. Again, it's the most common form of dementia. Early onset is usually familial. We know about Pat Summitt in the news recently. Excellent, stellar women's basketball coach from University of Tennessee. So early dementia is really a very much more small percentage. When people do get over 90, we're seeing about 40% incidence of dementia. Women get it 3 times more than men, likely because they actually live longer. So dementia progresses in 3 different stages. Memory loss, movement is usually normal. Stage 2, language loss. And stage 3, aphasic, typically with incontinence, and the person is usually in a wheelchair. Stages can overlap though. As I mentioned in that first stage, there's usually memory changes, there may be personality changes, difficulty with attention span, difficulty with orientation to the environment, increased anxiety, but the person's still able to carry out ADLs and socialize. Movement is usually normal. Second stage, usually memory loss is worsening, and there's no carryover with instructions, so you'll have to do repetition. Aphasia, apraxia, agnosia, low tolerance for stress, so a little more anxiety, more disrupted sleep, sundowning. Usually the person is still ambulating at this stage. Third stage, Person usually becomes incontinent. There's more severe aphasia, not able to follow directions, less mobility. So oftentimes persons are wheelchair bound or bedridden, oftentimes pulling into a fetal position. So you can see contractures here. So remember, this is not normal aging. True dementia, another form, is a Lewy body disease, and that's a subcortical form, falls in the category of Parkinson's diseases. Cortical would be more frontal types, like Pick's disease. Vascular dementia, as I mentioned earlier, less common, more abrupt onset, and more obvious focal sensor motor signs, more severe. So more sudden onset. So vascular is also called multi-infarct, and it's about 15 to 20% of the non-reversibles. So the person, typically it's like they're having small strokes. AFib is a common comorbidity. Usually a person has a history of hypertension, stroke, and blackouts. Hippocampal sclerosis, I'm not going to go very in depth in that, but that's kind of a more rare form. Has similar progression as Alzheimer's disease, abbreviated as AD. Frontal temporal dementia, or Pick's body, persons usually have more odd behavior. Memory is usually less impaired, but the person is typically socially inappropriate. Remember, the frontal lobe has a lot to do with how we present ourselves. It's kind of that, how do I put it? The person being able to hold back, to edit themselves. Creutzfeldt's-Jakob disease, that is an infectious disease. Typically, you're going to see myoclonus and pyramidal signs, and maybe picked up on the EEG, and usually the person declines rapidly within weeks. Death was usually within 1 year. Medical management, assume a cognitive change is reversible first, so that should be ruled out. Clinical diagnostic criteria and clinical tests are important. So later on, we're going to talk more about the outcome measures I've put up. And again, a diagnosis may not be definite until autopsy, so clinical diagnostic criteria and the clinical test are very important. Pharmacologically, there are some medications, probably know of Aricept. Prevention, ibuprofen has been something that has been shown to prevent dementia. At least there's some studies on that. Oftentimes it's managing the symptoms and especially any types of psychotic behavior. Risk factors. Increased risk with hypertension, diabetes, hyperlipidemia, family history, and genetics. So inflammation has been attributed to a lot of this. So on the flip side, lower risk with lower BP, statin drugs, physical exercise is extremely important. I'll talk about the NUN studies later, but if you don't know about that, I would highly encourage you to look into that. Moderate alcohol consumption, but not excessive. And good nutrition, fish oil, the omega-3s. Okay, that concludes, almost concludes the talk. I just wanted to mention mild cognitive impairment again. And this is not, it's sort of between normal aging and dementia. So the person could be at risk for getting dementia. 4 criteria are memory loss. Typically the person has normal ADLs, normal general cognitive functioning, and abnormal cognitive measures. So it could be more subtle. That's why some of these cognitive measures are very important. That concludes the lecture for now, and we'll be talking more about the measures I posted.